Unique model. It's really the first time it's been done in Maryland, and it's likely going to be with the HSCRC one of the first times it'll be done in the United States. So, with this type of model, so we're excited, and I think it's important to understand the reason for transformation and why rural hospitals have struggled over the years. And I think one is, of course, volume. And you have a lower population, hence rural, but rural is also distance associated. So you don't have 40 or 50,000 emergency room visits a year, or 5,000 patient days a year, but you still have 24/7 services you have to provide. And you still have the high-end expensive equipment, the information technology, and all that comes into along to providing good, solid, state-of-the-art healthcare. Because no one wants to have healthcare technology that was 20 years ago. I mean, face it. So you have to keep up with that. And rural hospitals have struggled being able to fund these efforts. Critical access hospitals first came about some time ago in the U.S. to address this issue in rural areas, in part federally and state funded. Maryland has a unique model. And so a critical access hospital, typically, if you would look at it, has 25 beds. And we can use those beds in a number of different roles. Critical access hospitals usually have some surgery, usually outpatient surgery. And I'm saying usually, I'm not saying all. And critical access hospitals always have a 24/7 ER. It's something that's absolutely required. And they have to have so many beds to stay open. Critical access hospitals pride themselves on their ability to network outside of necessarily the hospital environment. So we for a long time have thought hospitals as our place of care for everything, right? You go to the hospital, you go to the hospital, maybe you go to your doctor's office. But a lot of, with the advances in technology, the advances in pharmacology, everything that's happened over the years, a lot of the things that had to be done in a hospital can now be done very safely and effectively, even more effectively, in an outpatient environment. And the technology has allowed us to process and analyze and support all the data that comes along with the digital world. The focus in rural areas is really the focus on the population health. And the idea is, and I think if we go to pay for performance, the models in healthcare delivery now and payment models, the idea is to try to keep people healthy. Don't wait till they get to a point where they have to come to a hospital to have this care, because it's very expensive. There are always those parts of the hospital, it's time consuming, you have to wait for bed, all these things like that. So using the model that we're using, we're addressing the wellness needs of the community. We're addressing an aged population, or a more aged population that you typically see in rural communities. If you look at statistics between urban and suburban areas, you'll see a higher degree of aging, or people over a certain age. Unfortunately, you typically see a higher level of chronic disease and some other things like that too. So trying to address those needs through mobile wellness, try to address the needs through an age-friendly health system designation, which is very important, which we're working on now, and we're in the process, and we're making headway. I think we're actually ahead of that schedule, and we can talk more about that specifically. Designing an ER that's more friendly to geriatrics. Oftentimes we see folks come into the ER, and we're good at fixing them up and getting them right where they need to go, but they may be going home to an environment that's not safe, or they may not have another caretaker that can help them. So how can we support these folks? They don't have to keep coming to the hospital and getting admitted. How do we maintain their health at home so they have a happier life? And of course, reduce the cost of healthcare. Every time you walk into the hospital, your bills are going to go up. That's the nature of healthcare. If we can manage it in an outpatient environment, it's the best win for everybody. I think an MSTAT addresses the model of not having an ICU, and so many rural hospitals, and I've been in rural healthcare for over 20 some years now, mostly in executive level positions, and I've traveled to rural hospitals in many states for a number of things. And so typically, I'm not saying you never see an ICU in these rural hospitals, it's not common. Usually it's some agreement with a larger tertiary care medical center to provide those services and have some ability to transport the patient safely and effectively to that higher level of care. The MSTAT team comes in to help as a bridge between not having the ICU and making sure that the patient gets the best care in the emergency room, the best care in transport, and gets placed in the best environment for their care when they're received at that hospital they're being referred to. So
that's brilliant.
it really is. And so using technology and helicopters and highly trained people, it's a great time in history to take advantage of this. Well, we had a number of significant goals, 10 to 12 goals that we wanted to get completed by the end of July. And not boastfully saying, but happy to say we've hit those goals. Now, but it's well understood, and Laura and I, and we know very clear that we've got to the starting line, all right? So the idea is just developing a pro forma. What's it look like? What resources are going to need? A lot of that's all been lined up. So we're now at that stage where we can start implementing and developing and measuring and then and correcting and all along the process to build a great product, which is where we sit right now. So, you know, I think we're doing well in that area. So those goals include mobile wellness. Right. So, for example, the first step is how do you hire a mobile wellness team? So, we've hired a mobile wellness coordinator and a nurse educator and some community health folks to help us in that process. The things that we'll need. So, we're now looking through lots of population data and trying to understand what does the community need to address health concerns. So, we make sure that our plan applies the resources to the most needed areas. This could be it could be everything from a fire hall blood pressure screening test to a barbershop talk on smoking cessation or a discussion in a high school about underage drinking. It could also go to the far end of the extreme where we apply technology for in-home patient monitoring. That's a telemetry, so we can monitor the patient's blood and their weight to make sure they're not taking on water and all those things that are important, so we can make quick and rapid adjustments to their care, oftentimes, ideally, before they even have to come to emergency room. We've got to the point where I think and Shore Regional and University of Maryland has done a really good job at looking really what rural communities need and taking that so we can to design a program that will be effective. Culturally, it's not easy for rural communities to go through this change. I understand that. I think I've said before that hospitals are often interwoven into the fabric of community. They're the center of care for the folks in the community. Many of them were born there, or they had kids there, or how many times they've been to the ER, and their doctors used to be on the second floor. And so we understand that. We get attached to that, but at the same time, even in urban areas, it's not that model of care that used to exist 20, 30, 40, or 50 years ago. And we, like everything else, we have to move to that new dynamic, that new change. The good thing is we can take what we've learned in the past and apply it to the present and the future to most effectively use the resources. You know, I think sometimes all of us, no matter what it is, in our personal lives, our private lives, we see change is something not good because it takes away some control that we thought we had. And so I think trying to understand that and recognize that it exists in all of us, that there has to be some level of trust too. The idea that we are and the community wants to see the best health care delivered in the area. And we're all on the same page there. And so I would address that, say, look, we want this to work great. We're committed, and you're going to have to trust us. But part of trust, we're going to communicate with you. We've created a community advisory council. There are 8 members on it at this point. We've had 1 meeting. We've scheduling a second here in just a few weeks. And that's the exact reason, that interface, that bridge between what we're doing in these offices and on these hallways and these ORs and in the ER and what the community is seeing out there. Using best practice and what we know from rural community healthcare all across the country, there are a couple things specifically that we're working on to move in that direction. One is transportation. We know that transportation is often very difficult in rural communities. And so we're trying to develop a transportation solution for non-emergent transportation, for emergent transportation, and for general transportation. We understand that it's important also that people are able to go to places that bring them wellness that aren't necessarily directed towards healthcare. So we're working on that. We recognize the importance of geriatrics in the community because of our population. So we've hired an ER doc who had a fellowship in geriatology, and we're in the process now of hiring a geriatrician to run our Aging Center of Wellness, which is another project we're working on. We'll be transforming the professional office building, some of the work we're doing here in the hospital, to provide those services, many of those services very close and centrally located to make it easier for our patients. So I think that's key. We talked about mobile wellness, and getting out into the community to provide those services is going to be critical. We talked about emergency transport to overcome some of the concerns about the emergency transport team to overcome some of the concerns about not having an ICU. We talk about education. So we've hired a health educator, and they're orienting right now to be out in the community and finding ways to get messaging across about good health and taking care of ourselves. Key too is telehealth, and telehealth allows us to bring specialty services that no way could be supported in the community to a small hospital. So some of the telehealth we're offering is we have cardiology, we have endocrinology, we're going to bring infectious disease, we're going to bring gastroenterology, but we also have access to physicians in the system for pediatrics and cardiology should they be needed. So we'll continue seeing our menu of telemedicine. And importantly, we're in that age of electronic medical records, which reduces redundancy. It's safer. There's a lot of technology in an electronic medical record that provides safety checks, especially with medication, and checks for allergies that patients has. So we have actually a very robust medical record. All this information from telehealth are going to go into that medical record to continue supporting and documenting the patient's care. And the patients can access their record through electronic portals. So instead of calling the doctor's office 4 or 5 times and waiting to get it faxed, they can, if they choose, they can dial in with a lot of security and a password and get in and see